Hello, everyone, and warm welcome to all of you joining us from all around the world. My name is Dr. Saad Shaibi. I'm a medical doctor from Morocco, currently based in France, and I'm moderating this illuminating series presented by Dr. Karim Qayumi. This lecture will be recorded and will be available later on our educational resources on CyberPatient. The CyberPatient Expert Series is an ongoing collection of webinars consisting of highly yield topics given by a wide variety of healthcare professionals. The goal of the series is for students and faculty to directly engage with accomplished experts, build connection, and support the future of medicine and healthcare for all. Today's exclusive session is one of its kind, as it's bringing not only students, but also faculty together to discuss, learn, and challenge ideas and perspectives on the fundamental theories behind education. As I do remember today, when I was in my third year of medical school, I was really overwhelmed with all the medical knowledge I had to grasp in so little time, that one day I decided to stop everything because I needed to learn how to learn. And this is what we are doing with this series. Today, we will explore the basic concepts of behaviorism, cognitivism, and constructivism. We will understand what's behind clinical decision-making, and we will also talk about simulation as a method in medical education. Today's expert is Dr. Karim Qayumi. Dr. Karim has more than 50 years of experience in teaching as an innovator, as an entrepreneur, and as a teacher. He has achieved many accomplishments as a director of research for Cardio-Vascular Surgery, founder and director of the Center of Excellence for Simulation Education and Innovation at the University of British Columbia. He's also the chair of Technology-Enabled Learning and the regional director for the Royal College of Physicians and Surgeons of Canada. He's also the founder and CEO of Can Health International, a registered Canadian nonprofit charity that aims to equalize health education between developed and developing countries. Dr. Karim, you have the floor.
Thank you, Saad. Appreciate a very good introduction. Should I be able to share now? Okay. Can you see my slides? Great. Okay. And what is this? Okay. So I think we already did that. Dear Saad, dear young colleagues, ladies and gentlemen, first of all, I would like to extend my appreciation and gratitude for all of you to be here. And I would like to cordially thank you for participating in this expert series and also giving feedback to us so we can provide a better environment for your education. Today, I have been asked to talk about the fundamental theories behind education. I have to admit that by far, I'm not an expert in medical education, but I would love to share my 50 years of educational experience with all of you. So today, by the end of this presentation, you will understand the basic concepts behind medical education, or education as a whole. And that would include philosophical approaches to medical education, such as behaviorism, cognitivism, constructivism, and other theories that we're going to embark on. We also would understand what is behind clinical decision-making. We could look at experiential theories, transfer of learning, style of learning and other theories behind that. In the end, I will try to make you familiar with virtual simulation in medical education. And hopefully, we're gonna reach our objectives in the end of the session. To begin, I think there are always three important questions that people will always ask themselves or others. One is, what is learning? And the second one is, how do we learn? And how do we make clinical decisions and management decisions? In general, by definition, learning is a process that brings together cognitive, emotional, and environmental experiences for acquiring, enhancing, or making changes in one's behavior, knowledge, skills, values, or world views and visions. So that is education in general, that's learning in general. But when it comes to how do we learn, that's where the theories behind learning as a process comes. And to answer that question, first, I would like to ask myself, like in classical medical education, how do we teach? We use usually three important methods. Is chalk and talk, which means lectures, seminars, workshops, and others. Reading books, giving assignments, discussing patients, discussing research, and so on and so forth. And then see one, do one, teach one, also called Apprenticeship Model, which is very much used in medical education. Before talking about those specific theories, I would like to tell you that research has shown that after 3 months, the knowledge retention for lecture is about 5%. It means that when you're finishing this lecture, you'll in 3 months, you're going to remember only 5% of what I said. Reading is about 10%, but bringing audiovisual to it increases to 20%, and I hope our audiovisual would help that. Demonstration is 30%, a discussion group is 50%, practicing by doing, on the other hand, is 75%, and teaching others is 80%. So it looks like the apprenticeship model of see one, do one, teach one is the best method for knowledge retention. Now, we can go down into the educational theories and talk about those specific theories, and we can apply them to these methods. However, you have to understand that with 1 hour of lecture, I can only scratch the surface of these theories and philosophies. We will not have time to go into the depth, but we may in the future, if you choose, we can talk into depth about different specific aspects of medical education. So, to answer the question, how do we learn? As I said, the education theories comes, and there are about 3 philosophical frameworks, which we already talked about: behaviorism, cognitivism, and constructivism. So behavioral theory is saying that learning is change in behavior. So it strictly focuses on objectively observable aspects of education, of learning. And it's based on the academicians that are very famous, and 3 of them are recognized in the academic world. It's Pavlov, Watson, and Skinner. So Pavlov is actually, Ivan Petrovich Pavlov is a Russian Nobel Prize laureate that was just putting my phone down, sorry. it's gonna bother me all the time if I don't turn it off. I didn't turn it off before. So Pavlov came up with the theory of associative learning. So what that means, what Pavlov said is that there are natural responses to physiological responses, like reflexes, to specific stimuli that relate to that particular system. For example, if we smell food or see food, then our juices would flow from our mouth and from our stomach, right? So this kind of reflex he called unconditional stimuli. So unconditional stimuli are naturally occurring stimuli that would have a response from the specific system. Now, there are other stimuli that may not relate to that system, and he called those ones conditioned stimuli. So, for example, turning a light on and off or ringing a bell, these are conditional stimuli. So the geniusity of Pavlov was that he said, if we are going to put these two together, the conditioned stimuli and unconditioned stimuli, and we repeat that many, many, many times, and after that, you take the unconditioned stimuli that's physiologically related to the system, take out the conditioned stimuli will produce the same effect. For example, if you ring a bell and give food to the to a dog or an animal or a human being, then the juices would flow because of unconditioned, right? The food. But if you repeat this many, many times, as soon as then you take the food out and just ring the bell, the juices would flow into the animals. That is the famous experiment of Ivan Petrovich Pavlov. And that's called classical conditioning. So the other two major academicians who are very famous in this behavioral system are Watson and Skinner, as I said before. So Skinner actually was a very interesting person. He was a Harvard University professor, have written many books and things. And so, but he was a firm believer that that the freedom of choice is a fallacy. That we actually, whatever we do is predetermined by a condition of a previous action that we had. So to say that my free will, I'm doing things on my free will, he said that's a fallacy, and that's not true, because whatever we do is always affected by what we have done in the past, and the effect is not just done it, but whether we get a positive reinforcement or negative reinforcement from what we have done in the past. Like, for example, he was saying, if we do something good and we take a pleasure on it, or people say it's good, appraise us, then we do that again and again and make improvement on it. But if we are punished and we didn't have any pleasure of doing it, then we're not going to do this. That's why he was against the free will theory. But in any case, so he came up with the theory of apparent conditioning. So what it means is that he said that there is a part of behavior that is affected by reinforcement, by environmental reinforcement. And that's why you call it apparent conditioning. Watson actually took Skinner's theory very far, and he said that you can train anybody, and people can learn anything. And he said, well, give me a child and ask me what to make out of him, and I'll make whatever you want out of him. But Skinner actually built also, in order to prove his hypothesis of parent conditioning, he built this Skinner boxes that's very famous. So where he put the mice and pigeons in it, and he made those positive and negative reinforcements to make sure that the apparent conditioning is proven by experiment. But the idea of this apparent conditioning went so far that in England in the 50s, they were making these boxes for babies, scanner boxes for babies. Can you imagine that? Like they're putting these babies and conditioning them to make them as good as they want them to be. Thank God the behaviorism theory is not very popular any longer, so people are not doing these kind of experiments on human beings. The second major theory is cognitivism. So cognitivism says that everything about learning is happening in the brain. So it's the brain-based mechanism of learning is important, and it was promoted by Chomsky, and he promoted this on the basis of Gestalt psychology. And what Gestalt psychology is saying is that the sum of parts doesn't equal to the whole. So you perhaps have seen this Gestalt psychology picture. It's very famous. If you look at specific parts of the crown of this woman and look at the face of this young woman, you can see these specific parts, and you would think that it's a young girl, but if you look at the whole, it's an old woman with a very big nose and eyes in a mouth here. So what Gestalt psychologists propose is looking at the patterns rather than isolated events, and at the whole rather than fragments, because fragments are not equal the whole. But the cognitivism theory became very popular in 1968 when Richard Atkinson and Schifrin, they developed the mechanism of cognition, and it's called information processing theory. And perhaps you have learned this in physiology and other places, but I'm just gonna go through it very superficially. What the information processing theory is saying, that stimuli is coming to sensory perception, going to working memory, and then it codes and goes into long-term memory, and then short-term memory can retrieve this back and forward. So this is how actually the computers are also organized. So there's two important things to remember about the cognitivism. So one is that cognitivists think that the brain is the biggest processor, information processing machine, the brain of human being, right? And this machine considers the knowledge of the past experience. These are two important things about the philosophy of cognitivism. And to say what's the difference between cognitivism and behaviorism, cognitivists are looking always into individual learner. It's into the brain. Everything happens up here. But behaviorists are always thinking everything is happening because of the environment. So the effect of the environment on learning is more than everything else. The third important philosophy behind education is Constructivism. So Constructivism was proposed by Jean Piaget, a Swiss pedagogue. And what Piaget said is that learning is secondary to and dependent upon progressive reorganization of cognitive function. To teach, Piaget said, is not to reshape behavior, but to provide the environment for students to self-explore. The other Russian pedagogue, philosopher, Vygotsky, also was very fond of constructivism theory, but his idea was that human beings are not learning individually. They are learning in a social environment. Therefore, deconstructivism should occur in a social environment. That's why he came up with this theory of social constructivism. In the 70s, Peppard was the one who actually proposed to use computer-assisted learning, so to use computers to learn from. Although computer was used for learning even in the 50s and after the 50s, but the real education, as a real educational tool, it was proposed by Peppard. However, Peppard said that computers should be taught as a tool to enhance learning environment for self-directed studies, but should never be considered as a surrogate teacher. So it would not replace the teacher, but it would enrich the environment for students to learn better. And as you perhaps know, nowadays with internet and also social media and all these other technologies such as Zoom, suddenly computers become the biggest social creatures ever. So the computers assisted education now satisfied not only the constructivism, but also satisfies the social constructivism theory of Vygotsky. Aside from these major theories of education, I would like you to also be familiar with some modern theories, what's called theory of multiple intelligence. And this theory was also proposed by Howard Gardner, who in 1983, he wrote a very good book. It's called Frame of Mind. And I would like you all to just go and get it from the library and read it. It's a fascinating book. And Howard Gardner is also a Harvard professor. So what he was saying is that our whole system, not just medical education, is praised and based on linguistic and logical mathematical intelligence. And schools, if you're reading, writing good and you have good in mathematics, then you're a good student, right? If you're not, then you're in the back of the class, you're not a good student. But what Howard Gardner was saying is that there are other intelligences that human being has, like visual, like musical, like bodily kinesthetic intelligence, intrapersonal intelligence, interpersonal intelligence, naturalistic intelligence. So all these intelligences should be praised equally to logical, mathematical, and linguistics. For example, people who has bodily kinesthetic intelligence become very good athletes. Not everybody has to be a mathematician or scientist, right? Or a writer. So in addition to that, I would like to share with you also this very important concept that was proposed in the 60s by Knowles. What we are so far talking about, they'll say pedagogy, pedagogical philosophy, pedagogical this, pedagogical that. And the word pedagogy comes from two words, ped and agogy. Ped means child, as you all know, and agogy means leading. So leading a child. So all the educational theory is leading a child. So what Noel said that in universities, we do not lead a child, we lead an adult, a man. And adult man learn different than a child. So therefore, he came with the theory of andragogy. So andragogy means adult learning because and means man, andra means man, and agogy leading a man rather than leading a child. So Noel said, to prove his concept, he said that adults are learning on the basis of 6 important factors. One is that they learn on need to know basis, while the children learn everything, right? adults are more learning on self-concept and self-directed learning. They don't need chaperones, right? Adult has more experience than children, and so therefore their learning would be have a different span, and they're very ready to learn, and they're motivated to learn, and they're always also need a different orientation for learning. So therefore, he was saying andragogy is different than pedagogy. So we have to deal with adults differently than with children. So now, with that concept, I think we have went through understanding the basic concepts of educational philosophy. And we talked about behaviorism, cognitivism, and in constructivism, as well as andragogy and other concepts. Now it's time for us to talk about the decision-making, understand what is behind clinical decision-making. So if we ask the question from ourselves, it's like, how do we make clinical decisions? Research has shown that there are 4 types of thinking. There is reduced thinking, dispersed thinking, elaborated thinking, and compiled thinking. So reduced thinking is based on empty mind, which means that you know nothing, but you would like to talk about something. and this is when students didn't learn anything, but he wants to talk about something, and of course you wouldn't talk sense. So in dispersed thinking is when you have some information, you received some information, some books, some lectures, some patient you saw somewhere, but you can't put it all together. That's based on clustered mind, right? Cluttered mind. So we do not base our educational directions toward reduced or dispersed thinking. We're mostly make medical education based on elaborated thinking and compiled thinking, mostly elaborated thinking. So elaborated thinking is based on deductive reasoning. So we teach students how to ask questions, take history, do physical examination, find out the clues that matches physical examination to the history taking, and then from there you do some lab tests and investigations, and then you discard your theories that doesn't have a proof, and when you got proof for your theory, then you make a clinical decision and make a diagnosis and give some medication to patients. But it's a very long process, and people needs to do this like very often. It takes hours, maybe sometime in the beginning of first year clinical, you will take days for you to do that. But it's a very good process. So it teaches you how to put clues together to come up with the right conclusion. But when the student is finishing medical school and goes for practice, within the next 3 to 5 years, they would switch from elaborated thinking to compiled thinking. And compiled thinking is based on recall, recognition, memory. If you worked in a clinic and you have seen like hundreds and hundreds of patients coming with a specific pathology, such as gastrointestinal or heart or lung pathology, then the next patient comes, you don't go and put those clues together based on your recall, based on the memory that you already have about these type of patient. You make a very fast decision with 10 to 15 minutes, and you prescribe a medication and make a clinical decision. So when people say, "Oh, doctor, you're so fast," within 15 minutes, you didn't pay attention to me. It's not true. We are working on a different level. So the recall, recognition, memory actually is related to transfer of learning that was proposed by Haftings. So first of all, I would like you to distinguish between transfer of learning and transfer of knowledge. Transfer of knowledge is from one person to another person. Like right now, I'm talking to you, I'm learning from you, you're learning from me, we exchange knowledge. This is transfer of knowledge. But transfer of learning is from the same person to the same person. It's how our previous experience affects our present or future experiences. And to understand that a little bit better, we're going to go again to information processing theory. And you can see that if there is a prior experience, you have a prior encounter, it goes to the sensory reception, and then it goes to short-term memory, and then it conceptualized, and it goes to the long-term memory. And in order to go there, what happens is that a few neurons in pathways would cluster together to form a network of cells in pathways that's called semantic network. That network represents that action that you learned in the past. So when the new encounter occurs, and if it's exactly similar as the one before, then you ask for that, you go and look for that a semantic network that is already formed, and you use that to do a reaction. So you don't have to actually learn things because you already learned it and it's there somewhere in your hippocampus. So, and that's called identical elements theory. And identical elements is if your prior encounter is exactly the same as your present encounter or future encounter. But people have asked questions, what about if your prior experience is not 100% the same as present experience? Can the brain retrieve that information? Because there is no such information there. So then people develop the cognitive theory of transfer. And what cognitive theory of transfer is saying is that actually for retrieval, brain is not looking for exact match, it's looking for similarities. So if you have similar experience, but very different in the past, it brings that so that you can build on the top of that. In Chan in 1993 actually made this for education, particularly in medical education. So what he was saying is that there are 4 stages of transfer. So stage 1 is orientation, when you explain things to people, and stage 2 is coaching, when you're taking their hands and making them do things. And then the stage 3 is when you are practicing it in fine-tuning it. And then stage 5 is when new information is solidified. So to understand this a little better, I will give you an example. Because I'm a surgeon, I'll give you a surgical example. When first students come to our department, the first thing we do, we teach them knot tying techniques, right? But we teach them a very complex surgical knot tying techniques, but they have already tied their shoelaces. Their mother taught them how to do that, hopefully. So if you know how to tie your shoelaces, you know some kind of a knot tying technique. So therefore, in stage 1, when we have the orientation, we explain knot tying techniques to them. Their clusters of neurons that is red in here in pathways would connect to the new ones. So we build new ones on the top of that, but it's very loose and it's not very stable. But when we coach them and take their hands and make sure that they understand it, then some of these new pathways would be forming and in new clusters would solidify. And then when we're fine-tuning them, then they may lose some of those bad habits and gain some better habits and so on. And when they practice, they go for solidification, which means the students are mastering now the knot tying technique. So the problem with medical education from my perspective is that we teach all these 4 stages of skill training in the OR, in the clinical environment, where we jeopardize the safety of a patient, or we make, to not jeopardize the safety of the patient, we make our education process a miserable experience for students and for ourselves. Don't touch that, don't close that. What are you doing? No, not doing this way, this way. So it's not a real good environment to learn. So the teaching is very ineffective. Now, with the new concept, if the stage 1, 2, and 3, we're going to do in a virtual environment, not just about surgery, about anything, about any skills, clinical skills. If you learn all these 1, 2, 3 in the simulated virtual environment, then we will give more time for the students to learn. They will have opportunity to repeat this very often, and there is no patient ethics or legal issues. So they can do whatever they want to learn in the simulation environment. So once they finish these 3 stages in the simulation environment, then they can go and look for solidification in a clinical environment. Of course, no simulation can change, can replace the real patient. But what we can do is to make students more ready in a virtual environment for the clinical environment. So also, we have been talking a lot about the experiential learning in the past few decades. And experiential learning is actually part of constructivism, because the learning by experience, learning by doing. So, and this is not something new. It has been, the idea was there from the time of Aristotle. Aristotle once said that if you want to learn something, do it. So learning by doing is not a new concept. However, there are new pedagogues, philosophers who brought new concept into experiential learning. But before we embark on those concepts, I would like you to understand that learning experience is very different than experiential learning. Because a lot of people are misusing this and are misunderstanding this. Learning experience is experiencing learning. It means that you can sit in a lecture hall. You can, right now, you're experiencing learning. Sitting in a lecture hall or a seminar, you would experience learning. But experiential learning is learning by doing. As when doing in the process of learning, so having experience in the process of learning. So the experiential learning theory become very popular with Coldin in 1984, when he came with a theory how people gain knowledge. And he says learning is the process whereby knowledge is created through the transformation of experience. So he Kolb's experiential learning cycle is very famous. So what he's saying in the cycle is that when we feel something, experience something, we start reflecting on it, and then we start thinking about it and conceptualizing it and improving it, and then we make an experiment on it, acting on it, and then we go back into the experiencing it. So and then the new experience will go again through the same cycle of reflection, conceptualization, experimentation, and experience again and again. And this is like a spiral going up and up and up all the time. So what what his major invention, aside from that, Kolb cycle, was also he introduced the learning style into education. What David Kolb was saying, his model was very simple. He said that we have two type or two category of experiences. It's a grasping experience and transforming experience. So the grasping is elements of the grasping experience as a concrete experience and abstract conceptualization. And the transforming experience elements include reflective observation and active experimentation. So what he was saying actually is that he, based on these categories and subcategories in those elements, he developed 4 styles of learning, because he said people have different abilities to learn, different way of learning. And one is called converger. So these are good thinker, practical applications of ideas, and they're using deductive reasoning to solve problems. So this is mostly the category of doctors, physicians. So they're very good at practical applications and deductive reasoning. Divergers are people who are thinking out of the box. And assimilators, there are people who can put theoretical models very efficiently into practice. And accommodators are people who are the labor, the real people who doesn't think and just do things and work. So his 4 type of style of learning was used a lot by a lot of people in medical education and also in education in general. And so what style of learning would give us is that it tells us that human beings have different abilities to learn. Therefore, they should, the education process, we should design according to each learner's capacity and individualize that. It's a very good concept in general, but people went so crazy with this concept that there is now over 70 different theories of experiential learning, and none of them are practical. And the biggest the biggest criticism that this learning style has is that some people say that with learning style, any of them, you have a preconceived idea about a student, about a learner. And then you want to fit everything into your preconceived idea that might not be entirely true. So therefore, it didn't go far, but in a lot of places, it is used, this style of learning. So amongst all the theories, I don't want to talk about all of them, but the one that relates to computer-assisted instructions and learning in virtual education, it's the NeuroLinguistic Programming model of Fleming. So what Fleming was saying is that people have different abilities, like different type of memories, actually. Some people have visual memories, can memorize by seeing things better. Some people has audio memories, can learn from listening. Some people has the reading and writing memories. You make notes, then you remember it forever. And some people has kinesthetic learning. So tactile, by touching and by looking and by feeling things, they remember better. So this is very good with respect to virtual environment, because in virtual environment, actually, you can use all these memories. And that's why perhaps a virtual environment is a better environment, because you capture all type of memories and all type of learners according to the Fleming's theory. While with lectures and things, you have only one type of memories, right? Also, people may think about interacting with computers, like clicking. You see, I say tactile learning is by clicking and looking around and clicking again and clicking again. It's not just about this, but also it's about interaction with the computer for attention retention. Because attention of a human being is about 8 minutes. If I talk to you after 8 minutes without any slides or without any distraction, after 8 minutes, you're not going to be able to hear me. You will come from here and go out there. So the reason people are putting these slides in interactions, most professors are in a live situation making different funny things and telling jokes and stories, is because they want to wake up your memory for a new 8 minutes of attention. But with computers, with clicking and going and back and forward and interacting, your memory is always refreshed. So the last issue that we're going to talk about here would be, I'd like to make you familiar with virtual simulation in medical education. So before talking about that, I would like you to know a little bit more about simulation. I'm not going to talk about simulation in general, because this is another lecture and we may have that some other time. But people identify at least 5 types of simulation. It's a live simulation, when a live person is acting on another live person and the live person is responding. It's like standardized patients, OSCEs, examinations, and things like that. Hybrid simulation, when you have a live person accompanied with a machine, for example, to give birth or to do urinary catheterization and things like that, people are using the hybrid simulation. So in virtual simulation is when a live person is acting in a virtual environment on a screen of a computer. And constructive simulation is when you're dealing with complex physical machines that has different parts. And when humans are acting on one part, those parts connect with each other, related to each other. And each time they connect, they respond back to the user or to the human being. And this is mostly is called high fidelity simulators, mannequins. You have seen high fidelity mannequins. In constructive virtual simulation is a different new thing. It's because in the past, the virtual simulation was like, I am just having a picture, I'm just having something there. But when you have inside the cyberspace, in a virtual space, a very complex machine that has a lot of components, and when you act on one of the components, all the other components collectively respond and give you feedback. That's I will call constructive virtual simulation. Now, CyberPatient is a constructive virtual simulation that we developed at the University of British Columbia. And you see here is my team who actually initially developed CyberPatient. So CyberPatient is an interactive learning platform that closes the gap between theory and practice of medicine and provides a virtual environment for students to gain competencies. So in a reality, a virtual CyberPatient is a virtual hospital with 135 digitally enhanced patients, so that student can go there day and night, 24/7. This hospital is open. The teachers can assign patients to students, and student can go and interact with those patients, give them drugs, do procedures, talk to them, everything that they can do in a hospital. And it's in a safe environment, of course, because you're not going to hurt a cyber patient. You just reboot the computer. And it's shown that it is about 10% of a standardized patient with a cost. It's much less costly. So if you look at the theory of see one, do one, teach one, which is the apprenticeship model, which we said is very good. In classical see one, do one, teach one apprenticeship model, it takes years of clinical practice for the students, as you can see here, to develop compiled thinking and become competent enough to give them independent work. And a residency training program, it's year 4 when you make them chief resident, right? And but if you use CyberPatient as a simulator, you can enhance this or speed up the process of education. You can show them one and then ask them to go and practice on CyberPatient 100 times. And when they do that, then it would actually increase their competency and compiled thinking levels very soon, within 1 or 2 years. Then you can give them more independent work earlier. So as a result, medical education would be much safer. It would be less costly, more effective, and more reliable. There are some research we have done with CyberPatient, and in Japan, the research was comparison of computer-assisted instruction CyberPatient to a textbook in physical examination, and it showed that CyberPatient was significantly better. Students learn with CyberPatient significantly better physical examination. The next study we did about history taking in Vancouver, UBC, University of British Columbia, and it also showed that, and it was compared to standardized patient this time, not textbook. And it showed that CyberPatient is as good, perhaps, as the standardized patient, but it's much less costly. And also nowadays, CyberPatient is used by many people around the world. In most of the surveys we get shows that the students feel that they're not 90% better in making clinical decisions than with normal way of doing things. So coming back to summarize maybe the educational theories in relation to CyberPatient, we can say that CyberPatient provide constructivism. It's based on constructivism theory of Piaget, because it gives you the environment to self-explore. And it is very much in line with social constructivism theory, because you can do it with your groups, with not just a group of students in-house, but at your university, but you can do it with a group of students all around the world. And this is based for transfer of learning, because every time you go through an experience in virtual environment, you improve your compiled thinking and improve your transfer of learning. It's based on Andragogy theories. It's for self-directed as well as instructor regulated. It's based on theory of multiple intelligences. It's also based on experiential learning theories, and also theory of learning style, and more importantly, Fleming's NeuroLinguistic Programming, because with CyberPatient, you have the visual, audio, tactile, and also reading and writing memories all together. So as a result, we believe that CyberPatient is the only disruptive technology that revolutionizes medical education and will provide benefit for everyone, including students, faculty, educational institutions, the healthcare system. Or reducing medical errors would improve medical healthcare system. And also regulatory bodies can use this for examination and things. And we are doing these type of investigations at this time. So in the end, I can summarize that we have touched base on understanding the basic concept of medical education, including behaviorism, cognitivism, and conservatism. We understand what is behind clinical decision-making, We talked about experiential learning theories, learning style, adult learning, and others. And we also are familiar with virtual simulation environment in CyberPatient as an example of that. There are other examples on the market. So this time, I would like to thank every one of you for your attention. I'm sorry if I was doing it very fast. If you have any question, please let me know and we can have a discussion. Thank you.
Thank you very much, Dr. Qayumi, for sharing your experience and wisdom on this interesting topic. I personally appreciated the walk through the history of modern learning concepts and also the insights on how these models fits in the medical and the healthcare education. This also was an opportunity for us at least to understand the big why students should learn about this, why faculty needs to integrate this in curriculum, and why there is a need to engage in innovative learning methods like simulation to enhance learning of our future care providers. I'm just inviting the students and also the faculty attending to ask questions in the chat box.
Sure.
So, Dr. Karim, the first question is from Amir. Is there any research comparing learning with CyberPatient versus real patients?
No, there isn't. And I think there is one study that hasn't been published yet, and it is done at the Kazan State Medical University. They sent me the data a week ago to look at. And the way they did it is that they did not, it's not like comparing with strict patients, but comparing to classical education, that patient is included in that. So what they did is they did by not by choice, but by force, because of COVID-19, many of their students could not come back to Kazan for studying. So half of their students stayed outside the country and half of their students was at the university. So they took advantage of this situation and used CyberPatient as a tool for those who are outside the country and compare it with people who were inside the country, and they did it inside the country and they did not give them CyberPatient. They went through classical, their routine education. And the results actually the results are measured by final examination. And it was surprising to me that the number of higher achievers in CyberPatient group was significantly more than the normal academic group. And the number of lower achievers was significantly lower in CyberPatient group than in comparison to the traditional group. So that means that with CyberPatient, there was a shift from low achievers to higher achievers, which that's what we expect. The paper we published in 1984 showed the same thing, is that lots of lower achiever and mediocre achievers would improve with CyberPatient significantly. But that's now in real life, not in an experiment, in a real life situation. But it hasn't been published. When it's published, I will be more than happy to send the paper to you.
Thank you very much. I'm seeing a very interesting question. What are the steps of simulation in education? If you can just provide some ideas to Sarah.
The steps of simulation? Okay, I hope I understand your question properly. There are, in my understanding, in my opinion, you should have, there are different types of simulation, as I mentioned, and every type should be as a stepping stone to the next level. So you always start from low fidelity, going to higher fidelity and higher fidelity, and going. So it depends what you simulate. If you simulate a patient, or you're simulating a scale. If you're simulating a scale, first, for example, I gave you the example of knot tying technique. First, we teach people in the laboratories, on pig feet and gadgets, right? And then they go to the animal lab and practice that's on animals, and then they go to the so it's all different type of simulation, different stages of simulation going forward. But in clinical simulation, it's much more complicated, and clinical decision making in the clinical environment. And perhaps I would say CyberPatient is an outstanding tool for that, because CyberPatient also has 4 steps. So that of complexity. So step 1 is it's called, we call it levels. Level 1 is for just history taking. Once you master your history taking, then you go to level 2, which is history taking plus physical examination. And then you go to, once you master that, you go to level 3, which is history taking, physical examination, and other decision making up until in the continuum of care from the time patient comes to your office to the time patient goes home. And we have an intelligent tutoring system that gives you all the feedbacks back. In level 4, but in level 3, if you make 3 mistakes, we allow you to move forward because we don't want to punish you. We want you to learn. But on level 4 is for internship, or for examination, where you should have been, you should not make 3 mistakes. If you make 3 mistakes, then you're out of the system. So CyberPatient for clinical reasoning and clinical teaching would have different levels, but for skill training, your curriculum should be designed as such that is from simple simulation to more complicated simulation.
Thank you very much for the response, Dr. Karim. I'm having this question from Shakiba. It's more about getting in the mood of learning. So she's asking, how can students benefit from studying when they don't have that much energy to study? And this is a big dilemma in the medical and healthcare world.
It's to stimulate them how to study. I think that's particularly for a younger generation, that's the time when virtual environment comes into play. Because as I said, it's more interactive. I give you, I'm not a young person, I'm very old, but I give you my own example. When I read a book or anything today, I mean, and after an hour or so, if the book is not interesting, or if I am physically tired because of other reasons, it makes me tired. But if I sit in front of my computer, I look at my time, oh my God, the time has passed. I missed my 2 appointments, I have to go now. So I think it's very good. And also the research that we did in Japan with Kochi and Jichi universities, we had 4 group of people. One group of people were just CyberPatient. Other group were CyberPatient with textbook. Other group was just textbook. And the 4th group was sham. They did not do anything. And we did OSCE examination before and after, and we did multiple choice question before and after. So during this time, we had 2 hours of instruction. So they have to self-directed learning. So we put a camera with their permissions to observe their behavior. The group that was with the textbook, for the first 10 minutes, 15 minutes, they're so concentrating reading. And then they start talking to each other. And then they start walking around. and then they go out for a cigarette smoking or something, or just finding an excuse to the washroom or whatever. So they do all kinds of things. But when we went to the CyberPatient group, after the 1.5 hours, I saw them, I have all these videos, that I saw them practicing on each other. So they were totally engaged with the computer, they're totally engaged. And then when they finished, they were practicing on each other right on the floor. So I would say if the person who is not sick or anything, I think computers will help them to learn. And also, it's not going to be boring, as I said, because of the Fleming story. You remember, they use if it's a visual person, well, they learn visually, right, better. So they're going to be interested. People lose interest in education because they don't understand it, or they get tired, or their memories are not there. If a person hasn't got audio memory, he would be bored with the lecture. So he needs, human being needs interaction. And I think, as I said, you know, the attention of a human being is 8 minutes. After 8 minutes, you have to do something to reboost your brain for the next 8 minutes. So I hope that would helpful. But if you can write me, we can discuss this maybe offline, because it's a very interesting topic to me also.
Yes, thank you very much. And I'm just also adding a little advertisement for the CyberPatient Clinical Club, as the question came from one of our founding members. We are already thinking of having some sessions to talk about this, how to implement some simple techniques like the Pomodoro technique to stay focused for a duration of time, and other concepts. So we will have a continuation of this discussion later. Thank you again, Dr. Karim, for joining us. Thanks also to all the students and faculty members who joined today. The recording of this session will be available to all registrants once the series is completed. And so we are really looking forward to meeting you the next week. It's on Tuesday, November 30. And I'm just insisting for you to check your emails so you don't miss this next opportunity. Thank you very much.
Maybe you can tell them what would be the next topic of, or you already sent it.
Yes, I tried to do some teasing, but the next topic will be exploring competency-based education, and it will be a great opportunity for us to discuss these concepts. Thank you again, Dr. Karim, and wishing you all a nice evening, morning. Thank you very much.
Bye. Thank you. Thank you.